Hi everyone, my name is Sharon Agacite and this is my presentation. A 42-year-old Filipino-American male presented to the clinic with complaints of cough for 10 days. He stated that the coughing is bothering him, especially at night. He reports productive cough with thick yellow color phlegm. He stated that he took over-the-counter Dayquil, NyQuil, and Mucinex DM. He has a history of hypertension and he is currently taking lisinopril. Um, he has no past surgical history. He said that hypertension runs in his family and his mother has hypertension. He has no drug allergy. He said that his immunization is up to date. He denies using alcohol, smoking cigarette, or illicit drug use. He is married and has 2 children. He works at Amgen as an engineer. For the review system, the patient states feeling tired. He denies any headache though. He complains of productive cough. He also complains of some wheezing, no nasal congestion or postnasal drip. No reports of shortness of breath, hemoptysis, or orthopnea. He denies any ear pain, no reports of palpitation or chest pain, and no nausea, vomiting. As you can see here, our patient have an elevated temperature. His heart rate is under 90. His blood pressure is 118/70. He looks ill appearing. I noted that he was coughing during interview or when I was auscultating his lungs. However, he's not in any acute distress. He is dressed appropriately for the weather. Upon the examination, his head is normocephalic and atraumatic. His tympanic membrane is intact and pearly gray with positive light reflex. Frontal and maxillary sinuses are non-tender to palpation. His oral mucosa is moist. However, I noted some erythema on the pharynx area. He has no lymphadenopathy. Chest extension is symmetrical with respiration. However, I noted bilateral expiratory wheezing, and it's present throughout all the lung fields. No rhonchi, no crackles noted. I don't see any sign of any consolidation. Cardiovasculars is unremarkable, no murmurs, rubs, or gallops. No, I didn't see any swelling noted. Abdomen is also unremarkable. No joint pain or swelling, no tenderness, palpation. Patient is alert and oriented ×4. He maintains eye contact throughout the examination and answers question appropriately. His skin is pink and warm. I don't see any cyanosis or clubbing of the fingers. So the main primary diagnosis for this patient is acute bronchitis. Acute bronchitis is associated with edematous changes in the mucous membrane of the tracheobronchial tree, epithelial cell damage, release of pro-inflammatory mediators, and increased secretion production. It is often caused by a virus such as adenovirus, influenza, RSV, or rhinovirus. About 10% are bacterial, such as strep pneumonia, H. influenza, Bordetella pertussis, and Mycoplasma pneumonia. Generally, acute bronchitis is characterized by coughing lasting between 2 to 3 weeks without any lung consolidation, such as we find in the pneumonia or any cardiopulmonary disease. Diagnostic testing is not generally indicated because cough is the predominant symptoms for acute bronchitis. Routine sputum culture are often contaminated with bacterial flora that normally colonize in the nasopharyngeal area. Nasopharyngeal swab tests can be used for influenza or pertussis. Also, chest X-ray if you suspected a possible community-acquired pneumonia. Signs and symptoms include coughing, difficulty breathing, wheezing, chest pain, fever, fatigue, headache. Symptoms care management are the treatment choice for acute bronchitis, antitussive medication to relieve cough, for example, Phenergan with codeine can be prescribed for severe cough at night. Antipyretics, a medication to help reduce the fever, rest, increase fluid intake. Um, Antibiotic therapy can be used for possible pertussis or community-acquired pneumonia. And the first-line drug therapy are the macrolides. The patient had mentioned that he had been called in sick for 2 days now, and he will be flying to Denver in a couple of weeks. I mean, not couple of weeks, couple of days for a work conference. So therefore, the treatment plan includes azithromycin for the next 5 days, Medrol dose back for the next 6 days, and Phenergan with codeine as needed for cough. Patient was also recommended to drink more fluids, rest, and if his symptoms worsen, we might get some chest X-ray for him. Patient was also recommended on practicing good hand hygiene technique, making sure that the patient and his family members are up to date with the recommended vaccines, avoiding smoking, avoid secondhand smoke, chemicals, dust, and air pollution. Patient was also instructed to cover his mouth and nose when he coughs or when he sneezes. Due to the increased concern of antibiotic drug resistance, it's also important to educate patients about it because it basically affects everyone. The CDC indicated that antibiotic resistance has the potential to affect people of any stage of life, as well as the healthcare, veterinary industry, and agriculture industries. The CDC says that each year in the United States, at least 2 million people are infected with antibiotic-resistant bacteria, and at least 23,000 people die as a result. The figure on the right indicates the timeline of the antibiotic resistance compared to the antibiotic development. As you can see on the bottom, in 2010, an antibiotic was developed, and the following year, an antibiotic-resistant bacteria was also developed. Dempsey and his colleagues suggested that despite efforts on discouraging antibiotic prescribing, physicians in U.S. prescribe antibiotic in over 65% for acute cough or acute bronchitis visit. The authors conducted a qualitative study where they discovered the primary care clinicians' perceptions about prescribing antibiotic for acute bronchitis. Although all clinicians agree with the guidelines that antibiotics are not indicated for acute bronchitis, there are some barriers. First is the perceived patient demand, which is one of the main barriers. Next is lack of accountability for antibiotic prescribing. Third is saving time and money. Fourth is other clinicians' misconception about acute bronchitis. Fifth is the uncertainty in diagnostic. And finally, the clinician's dissatisfaction in failing to meet patients' expectations. Possible solution includes patient educational materials such as handouts, quality reporting, clinical decision support, the use of an over-the-counter prescription pad, which is like a quick pre-printed form that the clinician can recommend non-antibiotic, non-prescription remedies to patients. And lastly, pre-visit triage and education by nurses to prevent future visits. The audits concluded that despite clinicians' perceptions, clinicians will continue to address patient demand and patient expectations. I mean, as a personal experience, my own preceptor tells me that a patient comes to the urgent care because they need treatment, and the expectation is often to get an antibiotic prescription. Like, for example, with our current patient right now, he had already missed work for a couple of days, and will be traveling the next couple of days. So the goal is to treat and make this patient feel better. And that is my presentation. Thanks for listening.